Hi, my name is Nicole McBrier. I'm a physician assistant and I work with Dr. Carrie Simo in the Department of Surgery at ProMedica Health Systems in Toledo, Ohio. Today, I'm going to talk about a laparoscopic management of a symptomatic liver cyst imposter. Most liver cysts are found incidentally on imaging studies, and for the majority of the time, they follow a benign course and there isn't much to do. Larger cysts, however, can become symptomatic, and depending on the size of them and their location, can put patients at risk for hemorrhage, rupture, infection, or compressive symptoms that could involve both the GI tract or the biliary system. Patients may complain of feelings of fullness or early satiety, or they may have increase in their LFTs or symptoms associated like a biliary obstruction. Different diagnoses of simple liver cysts include a variety of hepatic lesions that can have a cystic appearance. We think of things such as a mucinistic cystic neoplasm, hepatic abscesses, other necrotic malignant tumors, hemangiomas, just to name a few. The presence of the symptoms related to the cyst, or if the cyst has increased in size, should raise some concern as a provider. Simple cysts typically remain stable in size and cause no symptoms at all. Lesions that become larger in size or do give us symptoms become concerning for a biliary mucinistic cystic neoplasm or other rare cystic neoplasms and should be further investigated. It is imperative when doing the surgical procedure to always send a small piece of the cyst wall as an intraoperative frozen specimen. During these cases, we ask specifically the pathologist to rule out ovarian stromal tissue. Ovarian stromal can often be seen in both invasive and non-invasive biliary mucinistic cystic neoplasm. And if that would become positive on a frozen section, the next course of action would be to do a liver resection in that area. The clinical history for our patient is a 65-year-old Caucasian female who initially presented with some chest discomfort. She was referred to a cardiologist for a cardiac evaluation, including echo and stress tests, which were all negative. Her past medical history included GERD, and she was placed on a protein pump inhibitor by her PCP. Further workup was done was a limited abdominal ultrasound, which showed a substantial size liver cyst that was roughly 14 by 13 centimeters on ultrasound. It was about a year later that surgery consultation was actually initiated. And this was done more so because by this time the patient had become more symptomatic. She was having worsening satiety as well as right upper quadrant pain, and epigastric pain had continued. On physical exam, there was noted to be a palpable right upper quadrant mass. And on repeat ultrasound, it had shown that the cyst had grown to be over 17 centimeters in size. At that point, it was recommended that the patient should undergo a laparoscopic liver cyst marsupialization. Prior to surgery, a CT scan was ordered for preoperative planning, which denotes the large cyst. During surgery, the surgery lasted approximately 1.5 hours. The patient was positioned supine on the table. She also had a bump placed underneath her right side. Initial port site was placed at the umbilicus area, a 5mm port, and then 2 other 5mm ports were placed about 3 finger breadths below the costal margin, just to the right of the midline and to the right of the anterior axillary line. A harmonic was used to enter the cyst wall, where roughly 1.5 liters of cystic fluid were drained. At that time, a small 2-centimeter piece of the cyst wall was removed and was sent for intraoperative frozen, with the specifics to look for ovarian stromal tissue. We continue to mobilize the cyst wall and to marsupialize it using the harmonic. When we got close to freeing the wall, freeing the cyst wall, it was noticed that a fairly large vein was present and was entering into the cyst. At that time, the 5mm port at the umbilicus was upsized to a 12mm port, and an endo-GIA stapler using a vascular load was used to divide the vein. At that point, the remaining area of the cyst wall was freely mobile and was able to be removed out of the 12-millimeter port. An aquamanus was used to treat the surface area of the remaining bare cystic area on the liver, and hemostasis was maintained. The intraoperative frozen section did come back a simple cyst. The final pathology, however, came back as an adrenal pseudocyst. And specifically for the pathology, it showed numerous sections of different areas of the cyst wall with both a fibrinous rind that was consistent with a cyst wall without an epithelial lining, and many areas of a non-neoplastic adrenal gland around in the periphery. If we look at the pathology slides, the one under A shows the fibrinous cystic wall with calcifications. And under the B picture, we can see the fibrinous wall with the adrenal cortex, and that there is also a lack of an epithelial lining. The patient was kept overnight for observation and was discharged home on post-op day 1. At that time, she was tolerating a diet, her pain was controlled with oral pain meds, and she was ambulating around her room and in the hall. She was seen later in the clinic at a 2-week post-op visit. She had denied pain, her bowel function had returned to normal, she was tolerating a regular diet, and she was also having an increase in her appetite. She had some mild fatigue, but that was also resolving as she was getting back to her normal activity. And her symptoms from pre-operative case had all resolved. At this point, she just needed to follow up if any other symptoms or problems arise. So if she developed any similar symptoms, then she would be further imaged or other laboratory workup could be obtained. Adrenal cysts and pseudocysts are actually fairly rare in the general population, and the literature actually only reports less than about 0.2%. Pseudocysts do, however, make up about 80% of the cystic adrenal masses that are there. They are often found in patients between the ages 30 to 50. They are seen greater in females with a 3-to-1 ratio to males, but there does not seem to be a relationship between pregnancy and the development of these cysts. The vast majority of them are diagnosed when they become symptomatic due to tumor size. We don't really understand how they arise. We think it's from previous infection or hemorrhagic process, but there seems to be no clear-cut answer either. They may be isolated or associated with a primary adrenal neoplasm. Adrenal cysts, similarly to liver cysts, can often be monitored with close surveillance, or they can be treated operatively. Surgical intervention is often recommended for cysts that are greater than 5 centimeters, clinically symptomatic, or they have features on imaging that make them suspicious for malignancy. For a benign adrenal pseudocyst, no further testing is indicated unless the patient's symptoms return. Thank you.